Giant retinal tears, or GRTs, are full thickness retinal breaks that extend circumferentially for 90 degrees or more, or at least 3 clock hours. They're rare, but they can be sight threatening, and they're more often likely to lead to a rhegmatogenous retinal detachment. The risk factors are really young myopic males, but they can also occur in trauma, aphakia, connective tissue disorders like Marfan's or Stickler syndrome, or inherited vitreoretinopathies. And a significant proportion can be bilateral, so examine the other eye always. If you've ever got a patient with flashing lights and floaters, always examine the other eye. I've had patients who complain of flashing lights and floaters in their right eye, have nothing at all in the right eye, and then in the left eye have a retinal tear. So patients may not always be the most reliable historians in terms of the laterality of their condition. So, GRTs result from abnormal vitreoretinal adhesion and liquefied vitreous, which then exert traction and tear the retina. Usually it's at the posterior edge of the vitreous space, and that flap of the retina may invert, and that can actually make reattachment more challenging. And, patients may have flashing lights, floaters, vision loss, but on examination you'll see this wide circumferential tear, as we're just about to see here, with rolled posterior edges, and that often makes the retina more mobile and accumulate subretinal fluid. Management is usually surgical, vitrectomy often combined with either silicone oil or heavy liquids, followed by laser or cryotherapy, tamponade with oil or gas. So in some cases you can even use a scleral buckle. Visual prognosis really depends on macular involvement, as always with retinal detachment, the presence of proliferative vitreoretinopathy, PVR, and surgical timing. So I hope you found this video useful. And my key takeaway is always examine both eyes fully.